to this scientific session I am Dr. Ankush Gaikwad from MCure Pharmaceuticals. I welcome you all on this Sunday on this scientific session called No Thrombosis in Workshop Series in Acute Ischemic Stroke. Yes, my slides are not moving. One second. Yeah, yesterday we celebrated World Stroke Day, and it was a good day for awareness of stroke. I found some of the interesting pictures on social media, which really emphasizes the message of World Stroke Day. And the theme for World Stroke Day was precious time. Some of the pictures of this World Stroke Day, which we see on this social media, is a wall with a lot of clocks and doctors standing besides, and members of World Stroke Association pointing at their wristwatches, which really emphasizes the need for urgent referral of patients and emphasizing the message of this awareness day that of precious time, which is really apt message for this day. Now it's my really honor and pleasure to introduce our faculty for today. Our course director, Dr. Ashokan. Sir is working as a chief neurologist and head of neurosciences at Sri Ramakrishna Hospital, Coimbatore. He has more than 3 decades of neurology experience. He's a life member of Indian Academy of Neurology and Neurology Society of India, an active member of American Academy of Neurology, member of MDSI, and a president of Coimbatore Neurology Society and Tamil Nadu Pondicherry Association of Neurologists. Sir has presented various national and international conferences and delivered lectures at these conferences and has special interest in stroke therapy. Welcome you, sir. I'm also pleased to introduce our moderators for today, Dr. Rajiv Anand, who is working as a Senior Director in Neurosciences at BLK Max Super Specialty Hospital, New Delhi. Sir has nearly 4 decades of experience in neurology and is a valued member of various prestigious medical societies and associations, including American Academy of Neurology, Neurology Society of India, Indian Academy of Neurology, Indian Epilepsy Association, to name a few. Welcome you, sir. Our second moderator for today is Dr. Amit Batra. Dr. Batra works as a principal consultant neurologist at Max Balaji Super Specialty Hospital, Delhi. He is a ASN certified neurosonologist, recipient of DMA Vashisht Seva Chikitsa Award in 2018, reviewer of BMC Neurology, executive member of Society of Neurology, and has special interest in stroke, headache, and neurosonology. Welcome, Dr. Batra. I'm pleased to introduce our 2 dynamic speakers for today. Dr. Suhas Murli, who has done his MD, DM and DNB in neurology and works as a consultant neurologist and stroke specialist at Neurocare Clinic and Kamakshi Hospital, Mysore. He's a double gold medalist both in internal medicine and neurology, and winner of prestigious Dr. Prabhakar Kore Gold Medal, Shanta Devi BS Patil Gold Medal, and other gold medals. He also works as a chief sub-investigator for multiple landmark trials like the Thalas trial in stroke, Scarlet trial in DIC, and the Kalavi trial in COVID-19. He has won various quiz and posters, and he's also author of multiple textbook chapters and peer-reviewed national and international journals. Our next speaker is Dr. Vishal Chafle. He is at MD, DM, and DNB Neurology, and also has done fellowship in intervention neurology and works as a consultant and intervention neurologist at Apollo Hospitals, Navi Mumbai. His area of expertise are stroke and endovascular interventions of vascular disorders of brain and spine, and has many publications in index journals, delivered talks in numerous international and national conferences. He's a member of IAN, ISA, SNVI, and IMA. So thank you so much, all the faculty members and speakers, for joining for today. And now I would hand over to Dr. K. Ashokan, sir, our course director, to set the opening remarks and take over the proceedings of the session.
Thank you, Dr. Ankush. So good morning, all of you, and I thank every one of you for sparing time on this Sunday to attend this webinar. I thank Team MCure for setting this platform to discuss our thrombolytic therapy and mechanical. Am I audible? Yeah, mechanical thrombectomy. It's going to be more of a case discussion. We'll learn many things out of this discussion. We discuss our practical problems and get solutions for the same. We gain knowledge by reading books, journals, and browsing the internet, but get wisdom only by experience and listening to the experts. So this way, this program is on for the past 2 years. Most of us have benefited with this program. Hope we will also cherish this program soon. And as told by Dr. Ankush, we have got two eminent stroke people, Dr. Rajiv Anand and Dr. Amit Batra, and two fantastic speakers, interventional neurologists, Dr. Suhas Murali and Dr. Vishal Shafle. And they are going to discuss their cases and we'll listen to that. Over to the host. And shall I call upon Dr. Suhas for his presentation?
Yes, sir.
Yes.
Go ahead. Sir, are my slides visible?
Very much visible.
Yeah, sir. Thank you. Initially, I would like to thank, at the outset, I would like to thank MQ Pharmaceuticals and Dr. Ashokan sir and all the chairpersons and moderators and my fellow speakers. It is a wonderful opportunity. We are now today, for 1 day post our World Stroke Day. And like sir said, it's very important for us to learn. Neurology is not, as Dr. Charles Miller Fisher said, you learn neurology stroke by stroke. That is what we are here to do. We learn neurology stroke by stroke. Each case teaches us something important. All of us usually discuss success stories, but today I'm here to discuss our failure stories. When we do mistakes, and when things don't go according to plan, those are the moments when we actually learn. Today we'll be discussing on, this is my profile. First, I would like to present this patient, a history of this patient, Mr. SK, a 50-year-old gentleman. He was a resident of Mysore and he presented to our emergency department on the 2nd of February with an acute onset of right-sided hemiparesis and dysarthria and a hemifacial weakness. The ictal onset was at around 9:30 p.m. on the 2nd of February, and he came to our hospital emergency at 11:30. Of course, he was in the window period at about 2 hours, and there was no contraindication for thrombolysis, no absolute contraindication for thrombolysis. The RBS at admission was 302, and he was a known diabetic on irregular treatment for the last 15 years. The NIHSS at admission. As I said, he had minor facial paralysis, which scored 1. He had arm weakness on which scored 1, both the arm and leg. And along with that, he had some amount of sensory loss, and there was dysarthria. So the NIHSS score was 6. This qualifies not. This just comes out of minor stroke, wherein the NIHSS should be less than 5. This was a first very early part of moderate stroke. So what do? We got a CT done. Initially, the CT, the pilot NCCT, showed a very small hypodensity in the left basal ganglia insular region at the level of involving the lentiform and the capsule. The aspects was 8 because if we negate the 1 point for the lentiform and 1 point for the internal capsule, we get an aspect score of 8. So what do we do? Was there any a contraindication for thrombolysis? None that we could make of. And so we went ahead with thrombolysis. We went ahead and thrombolized the patient. Patient weighed 70 kilograms. So we used 10 hectares at a dose of 0.25 mg per kg. The total dose administered was 17.5 mg, and the time of thrombolysis was 12:15 a.m. on the 3rd of February. The interval was 2 hours, 30 minutes from symptom onset. Now, as we all know, this is one adage that we can just adhere to. We keep hearing in every talk that time is brain. It was actually quantified. Every second matters, like how Dr. Ankush just mentioned. Every second, precious time matters. Every second matters because we are losing close to 32,000 neurons per second. If we take, for example, the locus coeruleus has just around 80,000 neurons. So all it takes is just 3 seconds for the locus coeruleus to get destroyed. That is the amount of loss that we have. And hence, what did we do? This is the ideal time frame that we should follow. At 0 minutes, when the patient came, this is the door to immediately the patient came at 11:30 p.m. We got the initial evaluation within 5 minutes at 11:35. We noted the stroke team was notified by 11:40. Then the CT scan was done by 12:05. The aspects was assessed by 12:10, and we initiated we gave the tenecteplase at 12:15, which was within 45 minutes. Now, what outcomes? How do we assess once we do the thrombolysis? What are the two outcomes, important outcomes that we assess immediately? Clinically, we look at the NIHSS. Radiologically, we look at the aspects. Of course, in the long run, we look at the MRS. But not all stories are success stories. In our patient, once post thrombolysis, the NIHSS actually worsened. There was worsening of the right arm and the right leg weakness, and hence the NIHSS went up from 6 to 8. We did a repeat CT again to see if there was, because whenever there is a worsening of aspects, ideally to say more than 4. When there was a worsening of aspects of more than 2, we got an imaging done, which showed a well-organized infarct. Again, the organized infarct was again involving the lentiform and the capsule. The aspects remain same. As we know, the more we learn from failures, the more success stories that we can have. The only way you can turn any failure into success is if you can learn from it. So where did we go wrong? Why did our thrombolysis fail? I wanted to know what were the predictors that I could have told the patient before when I am assessing what are the bad outcomes that I can be expecting given his risk factors. This is what I wanted to discuss, because success stories are okay, but failure stories are the ones that teach. Why should improvement matter? This is because stroke is one of the most leading causes of morbidity and mortality worldwide. The economic cost per stroke is pretty significant. As we go with the GBT data, which was published in Lancet in 2016, there is close to 5.5 million people who succumbed to stroke in 2016, whereas 116.4 million DALYs were lost, which is the highest. Now, as we know, after ischemic heart disease, now stroke is one of the leading causes of death and morbidity worldwide. Now, how do we define futile recanalization? How do we quantify something as a failure? As we know, when we go by the MTK score, we have 0 when there is no perfusion, 1 when there is minimal, partial reperfusion with less than 50% of the major vascular territory perfused is 2A. 2B is when it is more than 50%, more than or equal to 50%. 3 is when there's complete reperfusion. Failure, according to definitions, say that when it is 2A, up to 2A is what is called as futile recanalization. 2A is this MTK score when there is less than 50% recanalization of when the vessel opens up less than 50%. Now, what are the predictors that we were looking for in our patient? There are 3 important factors that led to failure of recanalization. 1 are the patient factors. What were the patient factors we will be discussing? 2 are the imaging factors. 3 are the physiological factors. What is happening to the patient? Patient factors, among the patient factors, there were various studies which were done to assess why patients did not improve. Some patients did not improve after thrombolytic therapy. They basically assessed failure of therapy as lack of improvement, which was defined by an NIHSS score at baseline and at 24 hours of 3 points or less. Poor outcome is when it is assessed by an MRS score of more than 2, that is 3 to 5 or 6. The assessment, this particular paper actually came out and discussed that there were 3 important factors which were statistically significant among the whole host of risk factors which was assessed, patient factors. The most important one was the glucose at admission. The glucose at admission of less than 140 had a very good outcome, whereas a very poor glucose of more than 200, 180 had a significant lack of improvement. And this was statistically significant. In our patient, the admission glucose was 302. Second, if there is cortical involvement, that can act as a very poor prognostic factor. We should know this. If a patient has a cortical involvement in the pilot CT, we need to make sure that we tell the patient that there is a risk that the patient may not attain the amount of success that we are hoping for. Third is obviously the time to treatment. The earlier we treat, the better it is. The outcome predictors also analyzed what happens, there were other studies which also assessed what were the outcome predictors for intravenous thrombolytic therapy in various other centers. All of them said the same thing. The initial diabetes control on multivariate analysis, which proved to be statistically significant, was diabetes, hypertension, and presence of atrial fibrillation. Now, what are the imaging factors? In our patient, we have one patient factor that patient had a very high admission RBS. And what were the imaging factors in our patient, which I could have predicted that the patient would not have recanalized well? There was a meta-analysis. This was a meta-analysis which was published of 3,453 published articles, of which 56 were included. They looked at the following imaging markers. As we all know, these are the signs of stroke. The hypodensity on NCCT, an unorganized hypodensity, I need to be clear, hyperdense MCA sign, or the HMCA, the leukoariosis, hyperdense MCA dot sign if it is in the M2, M3 segments, a clot burden score, this on CT angio, perfusion markers, and of course on MRI. I'll be discussing each one very quickly. Hypodensity on NCCT, as we all know, the hypodensity on an organized large more than 1/3, according to both ECAS-1 and NINDS-2, both made sure that they did not include patients who had an infarct of more than 1/3 MCA territory. Our patient did not. He did qualify. Next, hyperdense MCA sign. Although its appearance is associated with a poor outcome, we need to look at its disappearance after thrombolysis. That carries a very good prognosis. If the MCA sign disappears, it means that the infarct is most likely to be striatocapsular, involving the basal ganglia and the internal capsule. If the HMCA persists, it most likely means to say that it involves both the cortex as well as the striatocapsular region. In our patient, the HMCA in the pilot scan was like this. The HMCA was very obvious. After IVT, after the tenecteplase, the HMCA was almost the same, but very minimal decrease in the Hounsfield units. The human eye can detect a change in Hounsfield units of 5 units. Of the 5-unit change, if in the brain, if there is increased water collection by more than 2% to 5%, there will be a drop in Hounsfield unit by 1 unit. There was a significant drop of 16 units, but it still did persist. As we know, the length of the thrombus also is an important sign. This is the notorious artery that we all know, the middle cerebral artery, of which this is the average length. The middle cerebral artery, the average length on the left side is somewhere around 27 millimeter, and on the which is both have an approximate 3 millimeter diameter. More than 10 millimeter of the length of the clot has a very poor prognosis. In our patient, the next of course was the density of the thrombus. This I need to highlight very importantly. When the density of the thrombus is very high, what is the outcome predictor? Why is there a difference in the HMCA density? This is because we have two forms of clots. One, which is a platelet-rich clot, as we can see a lot of platelets which trap the RBCs within them, but this is basically a platelet-rich clot, which is most often due to a thrombotic occlusion, whereas we have a RBC-rich or a red thrombus. This is an RBC-rich clot. Both of these have different signal intensities on the CT, on the pilot CT. They both give a different HMCA density. This was assessed as a predicting marker in patients to assess the outcome prediction following mechanical thrombectomy. They came to know that whenever the patient has a red thrombus, the Hounsfield units are likely to be very high. When the patient has a white thrombus, the Hounsfield units are likely to be in between 50 to 60. In our patient, even though the patient's Hounsfield units was 47, which most likely favored a thrombotic occlusion with a white clot, they will have a low Hounsfield unit, but they have another study like this showed that lower Hounsfield units gives a higher chance of persistence of HMCA. Again, in other words, this is what we were taught during our MBBS days. Thrombotic occlusions have a gradual improvement, whereas embolic occlusions improve very quickly. Just like that, embolic occlusions recanalize also very quickly because if they have a higher density on the pilot NCCT. Then the second point is presence of leukoariosis. In leukoariosis, the presence of leukoariosis, like for example, Fazekas grade 2 to 3, which qualifies to moderate and severe categories of leukoariosis, gives an outcome, brings down the chance of recanalization by close to twofold. They tend to have a poorer prognosis. Then, of course, we have the HMCA dots, the MCA dot sign, if it is involving in the Sylvian fissure, which is in the M2, M3 segments. And of course, we have the basilar, the hyperdense basilar sign. This is just for the teaching purpose. Then we have the clot burden score. This is just like the aspects. We look at the angio and minus it from a score of 10. When we minus it to get how long the clot burden is. Lesser the aspect score, just like how we have a poor prognosis, lesser the clot burden score, worse is the long-term prognosis. In our patient, however, the clot burden score was 10, which was good. Then come the perfusion markers. The perfusion markers which determine poor outcomes are the ones which have infarct volumes of less than 53 ml and a cerebral blood flow of less than 30% compared to the contralateral hemisphere. So assessing the imaging markers, and among the MRI markers, we have a diffusion imaging when they have a low diffusion aspect score, large lesion volume, and early infarct growth, flare, which have a lot of deep white matter hyperintensities like leukoariosis, and then a clot burden score of less than 6. These are the imaging predictors. Then, of course, in our patient, what determines early reperfusion? Early reperfusion means the patient has a good outcome. When the diffusion weighted lesion is more than 30% and more than 10 ml reduction in the perfusion volume. Malignant profile is when the patient has a poorer outcome when the diffusion weighted lesion is a large one of more than 100 ml with a perfusion lesion of more than 100 ml within more than 8 seconds after the perfusion, after the contrast. So why did our patient fail? There could be poor collateral status. Second, there could be microvascular occlusions. This can happen when there is something called as the I'm not getting the word. Something called as this thing hypothesis, when the clot begins to break and goes further and causes a distal embolization to cause a further cortical infarct. And the third is cerebral autoregulation. Cerebral autoregulation is basically powered by the blood pressure. So maintaining blood pressure and hence maintaining the autoregulation before, during, and after the thrombolysis is very critical. This is what determines the penumbral damage and hence the outcome. So remember, don't just give and forget in tenecteplase, or don't just give and watch in case of altiplase. Things can still go wrong. In our patient, what was the likely mechanism of the stroke pathomechanism? As we all know, shear stress is when the wall of the artery is pressed laterally, when the wall of the artery is pushed laterally. In our patient, the most important area, the cerebral circulation, has a very bad anatomical variants wherein there is a lot of twists and turns that need to take place when the blood flows all the way up to the cerebral vessels. This is where, when the blood vessels are taking a turn, that is where the amount of shear stress is very high. And these are the reasons where there can be a clot. In our patient, where there is a perpendicular turn, that is the reason why, if you look at a Formula One car race, that is the reason why at the turns where the car takes a turn, we call this as a chicane. That is where you need extra protection, extra comforting, so that the car can take the load. In our patient, when there is the vessels, the lenticulostriate vessels take out perpendicularly, branch out from the MCA at perpendicular vessels, that is where there is a lot of shear stress. And this is where the clot had happened. This is where the clots had formed. And that could also be the reason why there were thrombotic occlusions at the perpendicular takeoff points from the lenticulostriate vessels, which is why it could also mean that the chances of recanalization was poor. Thank you so much.
Thank you, Dr. Suhas, for your excellent presentation. With the permission of both the moderators, Dr. Rajiv Anand and Dr. Amit Patra, shall I open the discussion?
Yeah, sure.
Sirs, both of you, is it okay?
Yeah, sure, sir.
Yeah. Thing is, 2-3 things in my mind. The thing is, of course, rather it's a small infarct involving the basal ganglia, that will lentiform
Yes,
close striate area. So by which we presume it's rather close to the penetrating vessel.
Correct.
Morphology looks like that.
Correct.
But still, I think you have to rule out large vessel occlusion.
Correct.
Large vessel occlusion initially may present as a small infarct, might grow later. And if it is a really a large vessel occlusion, I think your CT alone may not be sufficient. And maybe as an emergency, you would have done MRI stroke protocol where you can make out the vessels also at one look. And if that is there, you could have, after thrombolysis, gone ahead and gone for thrombectomy, etc. That is one part. Another part, as you said very correctly, leptomeningeal collaterals, very important. Either thrombolysis or thrombectomy, these leptomeningeal collaterals are very important. If they are not well developed, whatever you do, probably it doesn't open up and the cortical infarct subsequently sets in and the prognosis outcome is going to be bad.
Yes, sir.
Yes. And another thing, you told about the red clot and white clot.
Yes, sir.
That's why we rather insist repeatedly, red clots are more permeable
Yes,
and
sir.
easily lyseable.
Yes, sir.
So that's why don't lose time. Yeah, that's what you have done in a very quick manner. That's within 2.5 hours.
Yes, sir.
So generally, I'm telling. That's why we insist upon faster thrombolysis, so that red clots are easily lyseable and permeable. It's very permeable. As time passes, what we get is platelet-rich white thrombi, which are more resistant for thrombolysis.
Yes.
Probably these are the clots occurring in the large vessels, and ultimately after thrombolysis, we end up with the thrombectomy to retrieve the clots. As you told, of course, high sugar. You said 200 plus, but to me, 200 plus doesn't seem to be that high. Maybe 300 plus or what it may be.
Yes, sir.
It does have adverse effect rather on the thrombolysis.
Yes, sir.
Yes. And another important thing, maybe we can give insulin.
Correct. Yes, sir.
Insulin and do that. Maybe you can take vitamins and do that. Likewise, your BP, all those things. Okay, fine. So in your particular case, I doubt only 2 things. Maybe large vessel occlusion, but you have ruled out later.
Yes,
you
sir.
Ruled it out later.
Yes, sir.
And ultimately, 4 collaterals.
Correct, sir.
Leptomeningeal collaterals.
Correct.
And a long clot.
Long clot.
Yeah, maybe that's the reason. That's what I can pursue.
Yes, sir.
Thank you, sir. So
one point I wanted to tell, but I forgot to mention there now was even though the hyperdense MCA sign was seen, but on CT angio, the clot burden score was still 10. That could just mean the vessel was calcified. They need not necessarily mean that the length of the thrombus itself.
Yes. Yeah,
that
that's
was one of the things that I forgot to tell, sir. Yes.
No, because this calcification, rather,
Yes.
you get miscalculation
Yes,
about
sir,
the
yes.
length of the thrombus. I
Yes,
agree.
that way.
Sir, one of you, sir, Dr. Rajiv Anand,
So
or Dr. Amit Batra.
So I was just interested in seeing the angiograms, because see, just based on that plain CT and predicting outcome, just I think the only predictor out of whatever you mentioned was high sugars. That's the only thing which you had at your hand to say, okay, the sugars are high, more than 300, and looks like to be the penetrating arteries, which are notorious, right? And many of us have seen these paraventricular as well as the basal ganglia infarcts, patients worsening because of sometimes even the hemodynamic factors playing a role, right? So these are end arteries, and suppose you drop the blood pressure a bit too much, that can cause the worsening of the infarcted area.
Yes, sir.
So I think I would be interested in seeing the angiograms, but other than that, just based on the CT, it would have been very difficult to predict, how this patient will do. Generally, the bigger vessels and distal clots, they open up better if they are the red clots. But just based on the CT scan and the hyperdense MC also did not seem to be really a hyperdense MC.
Yes, sir, yeah.
The cut was also a little tilted. If you take a thinner cut, I think you would have seen almost the same vessel attenuation on the other side.
Bilateral side, yeah, bilateral. Yes, sir.
Yeah. So I think that is what. But you beautifully highlighted, summarized at least for all of us. We could recapitulate all the factors which can adversely affect the prognosis of all patients who are undergoing thrombolysis. So if you have more of these, say advanced age, high NIH, presence of AF, high blood sugars, so all of these are thought to be predictors in various multivariate models. So if you have more of these, definitely at the onset, even without any of the clot burden or any other characteristics, you can at least prognosticate to the family that this patient is likely to have not an excellent outcome as compared to a person without these risk factors.
Yes, sir.
Rajiv, sir?
That was the main aim of my presentation. Yeah.
I agree with the comments by my predecessors, but I must admit that Suhas, you have brought out a very good teaching session. You have taught us I always like a teacher who thinks that the student don't know anything, and you have given us from basics to advanced what could have been, what we should do and what we should learn. A lot of things I have learned. I have another comment. Amit will agree that we normally do, even in patients where we are thrombolizing, after we have done a CT, we do a CTA also. And if it is a LVO, we proceed with the thrombectomy protocol, which was highlighted by both Dr. Asokan and Dr. Amit. So in this patient, maybe. And another thing, I also agree with my colleagues that some patients, despite everything, have a different phenomena that continue to worsen. And diabetes is one factor which I have found. I have given everything to them and still they worsen and did everything. So probably we have been highlighting that there is two things to management of stroke. One is to open the vessel, and second is to know the mechanism so that you can prevent the closure.
Yes, sir.
So I am baffled very frequently that we do not know the mechanism in all patients.
Yes, sir.
So your talk was very important to teach us that also. Yes, probably even more we need to learn. And I have another question, that 0.20 versus 0.25. Though approved dose is 0.20, the better dose is 0.25.
Yes, sir.
So I do not know if my patient bleeds, whether the quote will save me or not, because I have exceeded the DGCA approved dose. So that is another point about inactive place we often face, though we try to give 0.25. And Dr. Padma in her lecture also tells that I gave 0.25.
Sir, Padma ma'am, when she taught us, she told us very clear. If you are passing out of AMC, please give 0.25. Nothing else.
So no, but that Padma man, same, these are the people who are on the board to get it up to 0.25 approved. So I would like the our people in pharma
Yes, sir.
to get the right dose approved as soon as possible, so my colleagues are saved in case of any mishap which happens.
Yes.
So overall, I loved your lecture.
Thank you, sir.
It being a very good educative. The way you explained everything, whatever happened to the case does happen to most
Yes,
of the
sir.
many times with all of us. But
Yes.
your explanation was excellent. I have learned a lot. Thank you.
Thank you, sir. Thank you so much, sir. Thank you.
And
So
one more point to add on to what Dr. Ashokan said, that angio is very important because sometimes the seemingly small infarcts can turn out to be ominous. I just had a case yesterday. 49 years old male, my dermatologist, close relative, went on to a nearby hospital with just a minimal dysarthria and facial weakness. The neurologist there was a friend, and he called me saying that the patient has very minimal dysarthria. NIH is almost 2 or 3, and the MRI shows a very small parietal infarct, and I think the patient is okay. We don't need to worry about it. Somehow the family wasn't very comfortable, so they shifted the patient to my place. And when I saw him in the ER, he was almost 2.5 hours into the stroke, and he had almost recovered. I would say the NIH was close to zero. I took him for an angiogram, a CT angio, and he had a complete occlusion of his right ICA. And historically, when we asked him, he said he had been having some neck pain for the last 1 day, and probably he had a dissection.
Yes, sir.
Right?
Yes.
So the guy outside had loaded him with good dose of antiplatelets, statins. Patient was stable. So I said, okay. The interventionist saw, he said the artery is totally occluded from the origin, so let's not meddle with it, and let's leave him alone for the time being. So we said, okay, lie supine and hydrate him well so that there is no hypoperfusion. And as expected, 3 hours later, he had a very minor episode again where he had a slurring of speech that resolved within few seconds. We could not do anything because he had just been loaded with antiplatelets. We said, okay, let's watch. And in the night, which is almost 6 hours later, he developed a left hemiparesis, right? And I again pushed him for an MR angiogram with a DWI image. Thankfully, the angiogram was normal, because I thought if it is a LVO, which has happened now, we could have attempted a thrombectomy in such a patient in case he is able to traverse through that dissection. Thankfully, the angios are normal. The MRI definitely showed fresh patchy infarcts in the right high frontal. Probably he would have embolized from the dissected segment, because the way these infarcts are patchy and multiple in number probably look like an embolic phenomena. So I had nothing else to offer. I just took a risk and gave him a shot of low molecular heparin in the night.
Yes, yeah.
So there is no evidence to support dual antiplatelets.
Sir, but anticoagulation works wonders, sir, when especially
but he's already been loaded with 300 milligram of aspirin and 150 milligram of clopidogrel just 6 hours back. So I did not take that risk. But once he had that event again, I put him on anticoagulation 1 dose in the night. And overall, I think night he has been stable. So I'm keeping my fingers crossed. So this is how sometimes you can a very seemingly small infarct, you can say this was a TIA patient, would have you would have been not even careful. I had a hard time convincing the family that this patient needs to be in the stroke ICU. I cannot admit him in the room or the ward. The family said he is okay, there is no deficit, and why can't we admit? So that is where you need to be careful, because if this would have been in the room, things could have got messy. So very careful with even smaller infarcts, and don't let your patient leave the emergency without a vessel imaging, whether an MR or a CT angio. That is the dictum these days.
Correct. Yes, sir. Thank you, sir.
Thank you, Dr. Sugas, and thank you, Dr. Batra and Dr. Rajiv Anand, for your excellent discussion and comments. So with this, we'll move on to the next case by Dr. Vishal Safle from Mumbai. Dr. Vishal?
Good morning, sir. I'm here. Can you hear me?
Yes, very much.
Yes. Good morning, everybody. I'm just sharing my screen. Okay, can you see it, sir?
Yes, no. Your screen is not seen.
So can somebody from the management, can they share the screen from their side?
Host, can you please help him, host?
But sir, I do not have your presentation, sir.
Okay.
Let me try. So I think
You have there? Yeah, okay.
Yeah, let me try.
Yeah.
Just give me a minute.
Actually, some problem with my laptop, so I have to join somehow with the mobile. I'm trying.
No worries. Dr. Ankush will share the presentation. Give a time.
I think 2 slides were ask him to share the latest presentation which I sent yesterday night.
Yes.
I think Ankush, you need to make a full mode.
Yeah.
Maybe enable editing first and then full mode.
Yes, sir. Can you see my screen?
Yes. Dr. Vishal, your presentation is ready and flashed.
Yeah. Once again, good morning, and extremely sorry for this technical slack. So this patient is an acute ischemic stroke patient. Actually, I thought let us select a patient who is actually admitted at this moment in hospital. So patient is still admitted. He developed stroke on this Monday, and I will just take his story forward. What happened since Monday? Today is Sunday, day 5, day 6. So he's a 67-year-old gentleman. He's a non-diabetic, hypertensive. He developed acute stroke, left-sided weakness on Monday evening. Onset was at around 7 p.m. and he presented to the emergency room at around 10:30. So almost 3.5 hours from the presentation. So on examination, his blood pressure was 160/100, power was 4/5, left facial weakness, mild dysarthria. So NIHS square was not high, it was 4. Next. So this was the MRI. Immediately we shifted, we have protocol. We do CT scan, MRI, but MRI is widely available, readily available. So we prefer MRI. We get better idea and better patient selection and treatment. We can explain the patient in right way. So that's why we do MRI stroke protocol in our institute. This is a diffusion and flare. You can see some changes in the flare diffusion evolving stroke, which is not yet established on the MRI. Angio was like dicey. Actually, intracranial MCA was open on right side, but ICA was not seen. So NIHS was 4, ICA was occluded, but MCA was fairly okay. So we discussed whether to intervene or not and what is to be done. As so I thought MCA is open, why to intervene? Because MCA patient's NIHS was not that high. He was well preserved. So there it must be filling via the ACOM and not giving the major stroke. So let us thrombolize the patient. Let's see if there is minor occlusion distal. It will get cleared. So we decided to not intervene and just do the thrombolysis. Next slide, please. So this was the patient with low NIHS. MCA was patent. So we thrombolized with tenecteplase. 72 kg weight, no contraindication. As I mentioned, blood pressure was 160/100. We injected with the tenecteplase 0.25 milligram per kg, that is 18 milligram dose. Patient remained static. There was no deterioration in power, sensorium. Overnight, he was okay. Next day, morning at 7 a.m., we took update. He was okay. At 7:30, started deteriorating. He developed worsening of the power. There was left dense hemiplegia. Then there was facial palsy, then which was already there, which has worsened. Neck neglect. He developed gaze deviation. He developed altered sensorium. NIHS was 4 on arrival, and now till morning it was around 4-5, but it dropped to 16. So we thought, what is happening? So we did a first thought key there must be a bleeding or like that, but we did MRA. MRA showed some evolution of the stroke. We can see the now an MCA which was seen pretty well in the first MRI on arrival, which is not seen now. So there was some worsening of the intracranial circulation. Next. So this is the diffusion on the right side before, and this is after. Definitely worsening of the stroke and involvement of the new area. Next. This is the intracranial angio before and after. So MCA, which was seen nicely on first scan, which is not seen now. Very mild few arteries. It's attenuated MCA. So immediately, in view of clinical deterioration and occlusion of the MCA, we decided to shift patient for thrombectomy. Cath lab was activated and patient was shifted to cath lab at around 9 a.m. This is the DSA. We start under local anesthesia. The patient was, though he was moving, we can finish it off DSA part and sometimes first pass in local anesthesia only. So I did a DSA. It showed a tandem occlusion. The right ICA was occluded and we could not see the antegrade flow after a few centimeters from the origin. There was no antegrade flow into the intracranial right ICA, MCA. And surprisingly, the MCA is supposed to fill from the left side via ACOM, which was seen in first MRI, which was not seen. So there must be some clot there at the carotid T, which was preventing flow from the ACOM. So that was the reason for his worsening. So it was a tandem occlusion. So total occlusion of right ICA, no cross flow via ACOM, acute cutoff at the right A1, and there is no antegrade flow into the right MCA. Next. So immediately, as everything, we start a DSA. It is not only DSA, we start with a 9 French sheet. So we start, I exchange with the that 5H1 diagnostic catheter with a 9 French cello balloon guide catheter. We put into the ICA and or microwire and microcatheter. And I inflated the balloon and I thought, let us see what is happening. We'll just do mechanical suctioning with the 50 cc syringe. So I did actually thrombosuction with a manual suction. And next, and I could get some flow into the MCA. We can see multiple clots into the MCA, and but artery was quite patent distal there. And then I did a super selective angiogram to the microcatheter and found that the MCA was patent. So occlusion was not into MCA. Maybe it has got opened up by doing suctioning, and there was some occlusion into the proximal part. Next. So there was a severe stenosis into the petrous part after one more time I did suctioning. So I could see the opened up ICA, MCA, and there was severe stenosis in the petrous part. So immediately decided to go ahead with intervention. So rather than thrombectomy with the solitaire stent retriever, it was the time to switch over to the planned strategy. And there was a stenosis, and we were planning for the balloon angioplasty and stenting. So immediately patient was intubated at that time, and we loaded with the antiplatelets. Normally I give aspirin and clopidogrel, but here I was planning to put a drug-eluting stent. So I don't want to stent thrombosis, so I gave ticagrelor loading dose, aspirin 600, ticagrelor 180 milligram. Meanwhile, I prepared for stenting the infusions and all. Next, I did a balloon angioplasty by 2.5 by 15-20 cc NC balloon. We don't give full plastic, we just do with a nominal pressure. And I could open up mild. There was no significant improvement after plastic. Next, there was a reocclusion as expected immediately after 1 minute or 2 minutes. Next shoot. Next, again we did thrombosuction and I could open the artery, and I thought everything was in place. Let us open the artery and let's see what we can do, because we need a pathway antegrately. So without opening that artery, we can't get the pathway antegrade pathway. So stent was already there. So I put a stent. Next. So this was a 4 by 21 mm coronary stent, which was available on board. I deployed the stent and we got a good flow, and there was some clot in the proximal part of the stent, which was actually not due to stent. It was already there and it was forming there. Next. Then I continued with the mechanical suction, because you can see the cello was there. It is a balloon guide catheter. It was already in place. I just have to inflate the balloon and put a suction. So I could get everything in one suction. I could open the artery completely, and this is the post stenting and thrombosuction. We can get a good, nicely open artery, and next, good antegrade flow. So there was a recently formed clot and all. So I thought, let us have some, because I just given antiplatelet half an hour back. It takes some time to act. So I thought, let us cover that period with the infusion, tirofiban. So loading dose of tirofiban 10 ml was slowly injected over the period of 15 minutes. And we just keep checking the angio, 15 minutes, 30 minutes, 45 minutes. This was the angio after 45 minutes from the procedure. So ICS pattern, no clot, MCS pattern, ACS filling. So I would say TK3 flow into the MCA. There was no bare area in the capillary phase. This was the right CCA before. This is the right CCA after. This is next. This is the right intracranial artery. Petrous part was showing stenosis, and now after stenting, we can see the nicely open artery. Next. So check DSA after 30 minutes post stenting, pattern stent, right ICA, MCA. Patient was shifted to ICU in stable clinical condition. We kept him intubated. Plan was to do repeat CT because the thrombolysis was at night, prior night. So planning was after 24 hours after CT. And let's see what happens. Next. This was the CT scan which was done, which was fairly okay. There was no worsening of the stroke. The infarct size in the CT and MRI and recent MRI is quite static. No bleed, no mass effect, significant mass effect. It was not no mass effect. So patient was okay. Next day morning, we were very happy. Patient power improved, which was 0. It became again 4. He became conscious. In fact, he was trying to remove the tube. So we have to remove ourselves. So we extubated him and he was okay. There was no cage division. There was neglect. And there was significant improvement in IHS. Next. After about an hour, while on rounds only, we noticed that there is sudden deterioration of the clinical status. Power became 0. Sensorium was those same. He was conscious, but power becomes 0. So we immediately shifted him for the scan. Possibility was bleed or thrombosis or multiple possibilities because he was okay 1 hour back and now he's not okay. So immediately we decided to go ahead with the MRI again for better understanding. So luckily there was no bleed, which was expected. But you can see the slightly mild hemorrhagic conversion. Again, infarct site was more or less same. Slightly, maybe I think motor area was slightly more involved as compared to the previous scan, but no mass effect, no significant bleed. Then our radiologist said there is a poor flow into the ICA. So sometimes a stent in place will give the artifact. So it is difficult to comment on plain MRI. We have to do contrast MRI to comment on angiogram into the with stent in situ. Next. So again, we thought there must be a stent thrombosis, which was one of the possibility considering the deterioration in clinical status. So we shifted the patient, and I considered there must be a seizure also. Though somehow he was on levetiracetam, so I already asked him to give the phenytoin loading dose, and I shifted to the cath lab immediately. Let's see what is happening, and shifted for DSA and SOS thrombectomy. Next. So this was the DSA. Surprisingly, everything was very clean. In fact, flow was better. MCA is better. Stent is okay. No trace of the thrombus into the stent. Then possibilities. So we discussed. So what can be the possibility? So we thought it is the evolution of the stroke or involvement of the motor strip by some minor evolution of the stroke or some edema involving the motor strip, which is giving the only power deterioration, and sometimes that bleed, though it is not significant, but it was subcortical, minor. So it may be involving some significant part of the corticospinal tract, and which was giving the weakness. So we decided to continue the whatever present management, and we shifted patient to the ICU. Patient was conscious, was having power 0 when we shifted, and we continued with the medicine. So next. So these are the medicines. Patient is on aspirin, ticagrelor 90 BD, rosuvastatin 840 milligram, amlodipine 5 milligram. Mannitol, I thought let us continue for 3 days because creatinine was okay. Plan is to stop today. Actually, yesterday. Actually, we stopped the mannitol. Levetiracetam and heptine, somehow I continued. Though EEG was not showing any discharges, there was nothing and patient was okay. Maybe after 2 weeks, I will discontinue both antiepileptics. Present condition, today's video I have installed in my laptop, I can't share. So patient is conscious, following command, rise tube is there. Upper limb power on the left side is 0, lower limb power is 2 now, and we are okay with whatever we got the outcome, and it's day 5 from the stroke onset. And maybe tomorrow if remains stable, we'll shift to the ward. So this is present clinical condition. I think I just next. I will stop my presentation and we can discuss.
Yeah. Thank you, Dr. Vishal, for your excellent case and difficult to manage case. Okay. So first of all, I would like to agree with you. 1, 2, 3. Number 1, very first this thing, in fact, and they had shown clearly the MR angio, cross circulation already set in, so that right MCA is perfusing and not much of deficit, etc., etc. Definitely at this stage, we may not, as you correctly told, we may not plan for thrombectomy. Yes, thrombolysis. You have done thrombolysis. But problem, thrombolysis, after thrombolysis, things are getting worsened. Why? Number one, as all of us, as we know, sometimes, not every, sometimes after thrombolysis, you get a disintegration of the clot and the clot moves further, distally. So after thrombolysis, you can have two things, new infarcts or increase in the size, same area.
Yes, sir.
Yeah, likewise, you can have either a new infarct or the infarct size may increase because of the disintegration and the distal traveling of the clots.
Maybe.
Okay.
Yes, sir.
And you point out very clearly, left MCA subsequently not visualized well.
Yes.
But you said it's maybe at the carotid T occlusion. What I feel that carotid occlusion due to the disintegration of the clot has gone there. And which was pattern previously, now it is occluded and you are not able to see the thing. So naturally, when the MCA is getting occluded, you get a new infarcts in the cortex.
Yes, sir.
Ultimately, your core volume increases.
Yes, sir.
So finally, your outcome, everything depends upon the core volume.
Yes.
Core volume slightly increased, so there is setback.
Yes.
And you mentioned about small bleed. That's not an issue at all.
Yes, sir. That is not an issue, but here.
Yeah, this is not an issue. This sort of bleed, that too after thrombolysis and thrombectomy, this minor hemorrhage is not a problem at all. That means if at all your things are working well, that's what we can say. So that is not causing any problem. So I personally feel disintegration of the clot and distal traveling of the clot, occlusion at the carotid T level, etc., etc. You have managed successfully all those things. But ultimately, what happens? Stenosis. This stenosis, severe stenosis in the ICU.
Yes, sir. Petrus spot. Yes, sir.
Yeah, Petrus. Normally we get at origin and sometimes Petrus spot and anywhere. Okay. This occlusion, as you have told, yeah, we rather tried to open it by stenting. What we have done in our few cases, instead of trying stenting or ballooning, we have tried tirofiban straight away. Intra-arterial bolus tirofiban, followed by intravenous tirofiban for another 4-5 hours, coupled with aspirin, and later heparin, low molecular heparin. That has worked well in few of our cases. In few of our cases, of course, as you rightly told, angioplasty. But what happens? First pass is opening, closing. Second pass, opening, again closing. Third pass, opening, closing. Your angioplasty, again closing. So you have to stent it. Stent it. And on all these things, you are very lucky. You are not ended up with a major bleed.
Yes, sir. With ticagrelor, that was
only small specks of bleed.
Every time whenever patient deteriorated, I thought there is a bleed.
Yeah, and probably this is the best way to manage this case. I don't think, and I invite comments from moderators, please.
Yeah, my first comment is like what you said. He's done whatever was possible. So again, the question is, if we learn from this case, if not retrospectively doing things different, but prospectively. So here the mechanism of stroke, we are talking progression of clot from the occluded vessel. So wasn't this patient a candidate for the next such patient? Won't you do a DSA immediately after the giving thrombolysis? Because once you have given high doses of antiplatelet drug, then you are given this, you are lucky that, as Dr. Sokan said, that it didn't bleed. But we were, how many hours after tenecteplase we were doing all these procedures? So we were within 24 hours window and we were using very high doses of drug, which we normally don't use. So if it didn't bleed, it was lucky, but there were high chances that he would have bled. So I personally am learning from this case that whenever intervention has to be thought in a patient which is a thrombolysis failure and in a center and with your efficiency, I think you can go in with DSA, because here if you define the mechanism of stroke, carotid endarterectomy or carotid can wait, but if it is the cause of progression, it should be done immediately, as soon as possible. So that is what my take for this case is, or if any such case comes in future, this is how I think we should, whatever we do, but we have to do it simultaneously, admitting that thrombolysis has not worked. So if it is a thrombolysis has not worked and mechanism of stroke is an occluded vessel which can be opened, then it should be done at the time of first this thing. DSA should have been done, or and we should have tried to do whatever we can do.
So only some patient was well preserved. He was hardly NIHS 4. So in that, whether to touch or not.
But here the question is, Amit also said, we are seeing patient where we are blinded by low NIHS. It is the mechanism of stroke you have to. So Amit said that you don't send the patient off if everything has turned out to be normal. What is behind the cause of stroke? Dr. Subhash Kaul uses this term. I have learned from him. So whenever you are treating a stroke patient, we as a tertiary care or being experienced, or when you are doing such thing, I think you will also do it differently. You will not leave a patient who is not even improved. Because if you have that is how the large vessels are to be treated. And if large vessel was the cause of stroke, then it was to be addressed. Then my thrombolysis is not addressing it.
Yes.
So if you go back and look at the initial angios, whatever I can see in the images, definitely the right MCA, there's a huge difference between the right and the left MCA, right? So it does not look like to be a robust, healthy MCA flow on the right side. Even though the patient has a low NIH, this patient was bound to progress. And the other thing which you should have been very careful was the blood pressure. A little lowering of blood pressure in these patients can create havocs. You create these minor strokes into malignant MC infarcts. Other thing which I think I could have thought of and done differently if I were at your place, I would have done a CT perfusion for this patient at the onset, right after the thrombolysis. And if there was a huge perfusion deficit there, I would have, because see, if it's an adequate perfusion, I'm okay with it, right? Because you said the MCA looks okay, the stroke is small. But if there is a huge area of perfusion deficit, which I am staring at, which might progress in the next few hours, I would have definitely pushed my interventionist to go ahead and try and open up this ICA, even though the NIH at onset was low. One thing. Other thing is, I am just curious to know what is the protocol for antithrombotics or antiplatelets which you use, especially if you are doing an emergency stenting, because I have tried to look up the literature n number of times. I have not been able to find a guideline, and every time we have such a patient, we are debating with the interventionist what to do. He is very liberal with the antiplatelets. I am so scared. Everybody said giving 600 milligram of aspirin with ticagrelor or blood. And then once these patients bleed, you are in a tight spot because one, clinical worsening. Second thing is you have a stent in situ, and then you can't give them antiplatelets in higher doses. The stent also thrombosis. It is a total chaos. So I think we should have done a CT perfusion at the onset and then decided whether you could sleep comfortably with this ICA closed, or you would have done it there itself. Second thing is your comment on the protocol which you follow, at least for your antithrombotics in patients like this.
Normally, sir, we avoid giving ticagrelor. Even I put a flow diverter, I will avoid ticagrelor. I will give clopidogrel because more potent. So here, sir, last month only we did a similar case where ICA was M1 was occluded. There was tight stenosis. I gave 300 aspirin, 600 aspirin. I give aspirin 600 because sir, it will give action in 2 hours. And I generally give clopidogrel 300, but last time there was a clot formation. Then I have to give tirofiban infusion for next 12 hours. So this time I was pretty sure I will not use a self-expanding stent. There you can clopidogrel is sufficient, but here they are thrombogenic. They are more thrombogenic. So ticagrelor. Patient was not that much. Elderly patient more than 80, I will avoid giving ticagrelor. But here there was no other choice. In fact, sir, stenting is later. Most of the time we just do plasty and we wait. Sometimes you may not have to put stent also, but here there was occlusion, there was no other option. Right. So I think I was lucky. And the tirofiban I just give because I know I just have given in front of me the antiplatelets to cover that period. Only loading dose I have given, and I was waiting there only 45 minutes just to check DSA whether clot forms or not. I have not given any. And there is strict instruction, no Clexane mistakenly also. and I followed that protocol. Patient is somehow okay. Let's see, sir.
Right. But would you not agree that doing a CT perfusion at that time?
Yes, sir. Sir, this CT perfusion would have been a better choice. Patient said there are a lot of things when we do intervention in India. First is the cost. When we give patient an idea, they say patient is okay, we'll see. So there are a lot of other things. And when we try to intervene, so why to do DSA only? It is intention to do a DSA with something. So just to see, we don't do DSA here. So patient should be ready for, suppose at all he needs any intervention, he should be ready for that thing. So somehow the patients were not ready. Next day, the patient deteriorated, they were absolutely ready. They have to arrange the funds. So I think in India, we are dealing with a different this thing. We have patient, we know we should intervene, but we can't. We can't make it free on like that. So that is the problem.
Look at the total cost analysis. So a patient who deteriorates and then you intervene, then the cost obviously is going
that
to
be
be
no,
same,
sir.
but
That we know. They don't understand. Yes.
Morbidity in terms of the patient losing his productive years of life is more. So I think doing a CT perfusion at the onset in such cases is not at all a bad idea. Nobody minds that one CT perfusion, because that way, if your decision making changes, you will be able to save the morbidity, shorter the ICU stay for such patient, and overall I think the cost comes down. So my suggestion would be to do a CT perfusion or an MR perfusion, whatever your center best has the expertise in, and then decide, because just leaving on the NIH and a small cortical stroke, I would suggest you go back and look at the images. Your right MCA definitely does not look like,
no, it doesn't look like
to the left. Yeah. So he was. It was a time bomb which was ticking and could have blasted any time, which happened probably 12 hours later.
Yes.
So I think CT perfusion, learning from this case, would be to do a CT perfusion.
In Apollo, this case was not in Apollo. This was the Oja sir's patient and another in a different hospital. And I'm in Apollo basically. So we have a rapid protocol and all. We do that. But again, sir, most of the time there was the last case where M1 was occluded. Patient came, I think, 22 hours later.
Right.
Patient was NIHS for 2. And it was showing deficit. Relatives say will not do anything, and patient did well. So sometimes this artificial intelligence may not help.
Agreed. So definitely, so retrospectively, anything can turn. So patient said, don't do anything. That's perfectly okay. But I think for decision making, every case is different and difficult, right? So maybe.
Yes, sir. I totally agree with you, Dr. Amit Matra. CT perfusion is very important. But you have done already MRI. You could have done MRI perfusion.
Yeah, same thing.
So that you could have made out the diffusion perfusion mismatch there itself.
Right.
And if the perfusion was larger volume, as Dr. Batra said, you could have planned this thing. Anyhow, but still I agree with you. See, initially the patient improving, otherwise small one, but cross circulation seems to be normal. We are little hesitant to go for thrombectomy. We are little hesitant because thrombectomy not always without problems.
There was one worry, sir. While doing thrombectomy, at least we can see MCS open, and while we intervene to the ICA, some clot may go. So
that's what I'm telling.
MCA is open and it is going.
Yeah, that's what I'm telling. So cross circulation seems to be all right, and getting circulation from the opposite ACA through ACOM, and this MCA seems to be filling up. And the patient seems to be stable. And now we say this ICA could have been a chronic clot also. We don't know. It is not an acute one, chronic clot.
It is true.
But this is what you have done MRI beautifully in the first thing itself. That time itself would have gone for perfusion imaging. So that would have made out the perfusion volume. It was really much more. But your core volume itself is large. Your infarct size itself is large.
Yes, sir.
Ultimately, your clinical outcome is going to depend upon the core volume.
Yes, sir.
That itself is large.
Yes, sir.
So, anyhow,
low.
Yes, sir. Yes, sir. Say something.
No, sir. That's what I said. NIH itself was low on admission, but probably I think the distal embolization, which closed the collateral from the other side. Probably that
yes.
So maybe.
Till sir, patient is admitted, say fingers are still crossed. Let's see what happens next 1 week, because that is time again we can have hemorrhagic conversion of the infarct and maybe bleed. But let's see, patient is stable till it's day 5 today.
I think yes, the worst is over. I think at least for the hemorrhage. So whenever you loaded him, you gave him tirofiban, you had thrombolized him. So that was the time, I think, first 24, 48 hours, you could have expected the worst bleeds. Now I think the chances of him having a bleed in the next few days is less. So you just need to see how his rehabilitation helps him come out of this.
Yes.
Right. Okay, I think you did whatever you could have done on board, but maybe a little decision making early on can guide you better. I think you can prognosticate the families early on that this patient is a very potential candidate who can worsen, and we should be ready that in case it deteriorates, we'll have to go in quickly. So that gives you also a lot of safety that you've done whatever you could to prognosticate at the onset itself.
Yes, sir.
Yes, sir. Final comment. Dr. Rajiv Anand, sir.
I also feel if we have the protocols in India are dictated by the patient's financial condition, timing of patient, and when he comes to us. Otherwise, probably if we have a CT and a CTA and CTPA followed by that probably can answer the questions faster. So what we do is a CT scan and thrombolize the patient. If it is eligible for thrombolysis, and do a CTA and CTP simultaneously, it's a time. If that is permitted by financial or hospital policy, then probably the season will be faster. What Amit has raised the issue and what Dr. Shokan has raised. So we need to have a protocol which if we can follow with our patient, we can be faster in delivering it faster.
Thank you, sir. So thank you for your excellent comments. Thank you both the moderators, and I thank both the speakers. And we had a really very good discussion and very good learning today, and learned many things. That's what every time we are learning new things, and thank both the speakers for their excellent presentation. Thank you. Over to host.
Thank you so much, all the faculty members and speakers for this excellent, engaging discussions. I would like to thank our faculty, Dr. Ashokan sir, Dr. Anand sir, and Dr. Batra sir for very engaging discussions and adding value to the cases which are being presented. It was a very good learning platform. I would really like to thank Dr. Suhas and Dr. Vishal for presenting so brave cases where they had to do a decision making in a very short time. Thank you both speakers for presenting these cases very wonderfully. I also would like to especially thank Dr. Suhas for telling one thing, that you can turn any failure into success if you can learn from him, and this was a very useful quote personally for me also. So thank you, Dr. Suhas, for that quote also. So thank you so much, all the faculty members and speakers, and we would like to work in future also under your guidance for future more such programs. And with this, I close this session. Thank you so much. Have a great Sunday ahead. Thank you.
Thank you.
Thank you very much.
Thank you. Bye bye.
Thank you. Bye.